symptoms. So you literally could say motor neuron is something that affects the brain or spinal cord. That's the right answer. Or you could tell me a lower motor neuron is something that affects a peripheral nerve. Or give me a name of a nerve. It would be something that affects the sciatic nerve. Great, something that affects a cranial nerve. Just make something up, and as long as it's right, I give you points. If you say something wrong, I take off a point, and then we go at it again. Trust me, this should be really, really easy. Everybody should get full points. The last thing is something I want to demonstrate and kind of talk to you about is the whole motor learning thing. There are 5 things that we are doing with this. There are 5 subsets. The one, you're going to position your patient, your partner, in that position, and tell me 2 things that you could do. Tell me why the patient is in that position. That's the second thing. Give me makeup and impairment. And I'll give you an example of that in a second. Of those, you're going to give me one activity that you're going to do. So of the 2 examples, I'll say do that. So you perform that, and I'm going to say make it harder and make it easier. That's it. So with those, I have all the positions listed as well, but let's demo it. I'll demonstrate sitting because that's one of my favorite ones. So let's say Micah had a stroke of some sort and he has no sitting balance. So Micah, come back. Can you lift this? No way. So we're in the hospital. Micah had a stroke and he had a very poor sitting balance. So from him laying supine, I raised the head of his bed, so now at least he's sitting. That in itself is an exercise, because he's going to get tired after that. I know it seems like we can lay in bed like that, we don't get tired, but his abdominals have not been firing for a while, right? So that's going to tucker him out. How do we progress this? I can say, okay, Michael, what I want you to do is put your hand on your belly and one hand on your back. What I want you to do is draw your belly towards your spine. So we're doing a transverse setting exercise. Okay? And just hold it there. And as you're holding it there, I want you to talk. Count backwards from 10. Count backwards from 5. Whatever it is. The reason I like to do that is so he's not holding his breath. Otherwise, like 1, 2, right? And he could have Valsalva maneuver, increase his abdominal pressure, give him a new stroke. Or he dies. Right? You don't want to do that. You want to make sure that he's continuously talking. So one thing, I know there's many of you who might be shy in the class. Trust me, I didn't talk when I started PT school. Next thing you know, now you can't shut me up. Because you learn how to talk to your patients. You have to just, random things. Just make something up and go at it. Okay? Once he can do that, I can even make this a little bit more challenging by saying, I want you to close your eyes. Right? And just breathe. That's already more challenging than just sitting there, because if he had any cerebellar issues, you're going to see him start to sway a little bit.
So put a gait belt on him too?
On the bed, you don't necessarily need one, but no, for the legality of it, yes, you should. If I plan on standing him up or move him around at any time, gait belts would definitely be required. You don't want to accidentally drop a patient and say, hey, I didn't have a gait belt, there goes your license, right? From this position, one other thing I could do if he didn't have a stroke, remember, in sitting, I could do ankle, I could do knee, I could do hip issue, whatever I want. The other things that I want you to start keeping in mind is, if he did have a stroke, he might also start developing tightness of his hamstrings. So just by sitting like this, it could hurt him. So I would ask him, do you feel any tightness or anything down here? And if he said yes, then I'd be like, okay, let's bend both your knees just a little bit, right? And we would get both those knees bent, so now we can do the same exercise and we don't have to worry about overstretching those. Because whenever you stretch something that's tight, you may limit function. And I'll give you another example of that when we do quadruped in just a second. From here, we can progress to, can you put this back down? So we can progress that by taking the back off. No, keep it. Okay, we can progress by removing the back. So now he has to do more independent sitting. So this is static, right? Make it more difficult. His eyes are closed. Close your eyes. Open your eyes. Rather than just doing eyes open, eyes closed, I could add pushing or perturbation. I could say, don't let me move you, right? How do I know to do that? Remember the whole mobility, stability, control mobility, and skill. So he had a stroke, he's tight, but he can move his arms and everything around. This area is very flaccid, is very weak. So he has a lot of mobility, but no stability. So I can do co-contractions to develop that stability. From here, I'm going to then work on proximal mobility and distal stability, right? So I want this to be stable, and I want him to move his trunk. So for that, I can move him side to side, forward and backwards. I can also work on more dynamic stuff by saying, I want you to try to touch the point over there. More, 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 more. I could do that with a balloon. I could do that with a ball, whatever it may be. Forward, backward, side, side, up, down, all directions. Okay? How can I progress from this? Again, if his knees are bothering, I can bend. To progress him, I can have him now rotate, legs off the bed. And that already is more challenging. Why? Because when he was on the bed with his legs there, the point of contact was all the way from the back to the back of his leg, right? From his butt all the way down. So now he has much smaller contact. So it becomes a little bit more difficult. I can do the same thing. Pushing, pulling, whatever I want to add. Go from static to dynamic. Eyes open to eyes closed. To reaching to whatever you want to do. I could have him catching, I could have him throwing, I could have him as basic as I want. In that position, I could have him with therabands doing scapular retraction if I had to. Okay? Don't think there's only one thing you can do. There's 50 million things in every position. From here, once we get him nice and ready, what am I really going to do with him? What do you think? What comes after sitting? What position?
Planograde?
Before planograde.
Oh, quadruped.
Quad.
Viewing?
Hook line. Sometimes you don't even have beds that they're too soft. You need something at least somewhat firm. So you're right, I would get him standing. So from here, I would put a gait belt on him, right? So that's something that you would ideally want, or at least tell me about that tomorrow. So from here, I'm gonna have you stand up and hold on to this. Okay? So he did something really, really good. As he's standing, he made a fist. Okay? Why do I want him to make a fist and not have his palms out and extend and stretching his flexors?
He's gonna stroke and use flexors like that?
Correct. If your flexor tone and your flex, if I stretch that out, you're going to lose what we call tenodesis. And we're going to talk about that in a few weeks when we get into CVAs. And if you lose that ability by stretching this, guess what? When you try to eat, you'll actually end up slapping yourself as opposed to actually eating. Okay, so making a fist and being on that, it'll give you more stability. The downside of this, you have to be careful of, is if your patients have long nails, do not do this. Because what happens, their nails are going to dig into their skin. And it's sad, but it's true. You're going to see CNAs, sometimes they don't go with nail clippers and clip the patient's nails. And next time you do it, the patient's hand's all cut up and bleeding. It's all because they made a fist. It's not appropriate, but it's going to happen. So check for those things before you do anything. So in this position, let's say he had a left-sided CVA. Ideally, I'd be on the other side, right? You always guard on the weak side. So imagine me being there, but if I was, then you can see what was going on. So if I'm over there, stand up nice and tall for me. I can work on just posture. If this is too low, I can raise the height, or I can have him grab a higher shelf or whatever it may be. So if he has left-sided weakness, I'm on that side. And what I can do in the beginning is just have him weight shift to that left side. That's how you really want to start progression. Because as he bears more weight on the left, that left side gets more proprioception, more feedback, and he starts getting better. If I want him to do that actively, I could have him, can you bend your right knee for me? Just all the way up, just bring it all the way up. Bend it up, there you go, just slightly, all the way up, kind of just marching in place. Toe and bend, toe and bend. As he does that, he starts putting more weight on that side. And I'm guarding him so I know he's going to be safe. Okay? If I wanted to add more knee bending on both sides, knee flexion, I could do that as well. So he's one and the other, one and the other. Okay? He just looks like now he's dancing. All right. You're the only one that laughed. They're all serious. Okay. From here, if I want more weight bearing on the left, I could do the same thing. Lean forward, and then from here, kind of reach for something with your right hand. Kind of come here, right? And back down. It's not that I'm trying to strengthen this side, it's that I'm promoting weight bearing on the opposite side. So you have to look at what your rationale for treatment is. If I'm working on mobility, yeah, I can have him bear weight on this and try to reach, but what's going to happen? He's going to put too much weight on this side, and this side's already weak, so he's going to collapse. So you want him bearing weight here, I can hold him, this comes up, and then have him move around, and he's going to get better that way, much, much quicker. Does that make sense? I can do the same thing in quadruped, making sure he's in a fist, not in a completely straight position, and do a bunch of exercise. I could do ankle, knees, hips, core stability, maybe even head control. In this position, I could do head control. Say he had a weak neck, he had a car accident, and now he's Mr. Bobblehead, right? And I can say, can you bring your head all the way up, look up to the ceiling, look up to the ceiling, and get that muscle to contract. As he's getting better, maybe even putting a towel on his head and using a TheraBand and going against the TheraBand with his head. It's not a bad answer, okay? I could even do manual resistance front and back. Does that make sense? With rotation, whatever it may be. So does this make sense? Yes. Thank you. Does that make sense with what I'm kind of looking for tomorrow? Okay. And remember, if you're progressing or regressing it, it can be in the same position, or you might regress them to the position that's prior or in front of it. Because that's what I want you to understand as well. If you have plantar and the patient's all shaking, they're not ready for plantar. Maybe have them sitting down, or maybe have them hook line and bridge. That means their pelvis might not be stable. Because you have to have proximal stability to allow that distal aspect to move. So if you can't stand, that means the pelvis isn't working. Bridging. If the pelvis isn't working and he can't even do bridging, that could mean that his abdominals aren't working, so maybe we do some sitting exercise. If that's not working, let's put you in kneeling, short kneeling, tall kneeling, half kneeling. If that's not working backwards, we put him quadruped. If he can't get quadruped, let's just put him prone on elbow. If that doesn't work, he's probably just laying prone, working on head control. If that's not working, he's likely dead. So that's really what it is. Right? Okay. For the Therex test now, there are 6 things that you are doing. With the 6 things that you are doing, the first one, you're assessing active and passive range. Second, you're performing some sort of stretch or stretching exercise. Third, resistance or strength training. 4, aerobic or balance training. 5, you're going to be answering questions that are from your red book. And 6, you're going to document everything that you did. So again, 5 things in documentation. So I'll break it down and then we'll do a couple different examples. For active range and passive range, this depends on what and who your patient is, right? You have 6 different cases. You should know them. If you don't have to memorize them, you'll get a copy of them tomorrow, whatever random one that you pick. Based on the case, we're going to tell you that right now there's nothing wrong with the patient. Whatever cancer they had, whatever ALS, or whatever pathology they had, it's cured magically. They have nothing wrong with it, except for the orthopedic condition they originally came for. What would you do for that? So for that, you're going to assess active range of motion, have the person do something, and then you're going to do passive range. So 3 things. 1, place the patient in an appropriate position to assess active and passive range. Check active range, and then perform passive range of motion and tell me what kind of end feel you should have at that end range. Remember, everything for the most part is firm end feel, except for maybe hip flexion If somebody has a belly, that's going to be soft. Knee flexion will be soft. Elbow flexion will be soft, right? Everything else is firm for the most part. Hard and feel are going to be your elbow and knee extensions. And maybe, depending on which book you read, inversion or eversion, but let's just say firm. That's why they're not on your boards. Once you do that, second thing you're doing is stretching. For stretching, based on the patient's pathology, tell me an appropriate muscle, and you're going to be stretching it. So tell me what muscle that you would want to stretch, based on the case scenario, and position the patient. That's one. Second thing you're going to do is then stretch it. With stretching, you have to make sure your hand placements are right. You're going to put one hand where the origin is, one hand near the insertion. So that way you have full control of that body segment. The third thing you're going to do is perform strengthening or resistive training. So you're going to tell me 2 different exercises. Your instructor, whoever's grading you, is going to tell you to pick one of those, and you're going to do those, or they're going to pick for you. The other thing we're going to look for is your proper body mechanics, both for you and your patient. So just make sure you're not hurting yourself and the patient's not being hurt. The fourth thing, aerobic and balance training. Pick one of those. Does your patient, or will your patient benefit more from balance, or will they benefit more from aerobic? I don't know. It depends on the case. Whatever it is, pick one, and then you're going to perform it. So select an appropriate exercise. Actually, you're going to select 2. You're going to perform one, and then your instructor is going to say, make that harder or make that easier. The last thing you're going to do is answer the questions that are in the book, that are in the case. Usually it says, what are some of the red flags you should have noticed? What are some of the yellow flags? How are you going to progress the patient, the plan of care, whatever it is in the book. And then document everything that you did. Do not write everything from the case scenario. Don't write the patient's name. Don't write how old they are. That is in the eval. That's already done. Everybody knows that. You're writing new stuff. If you don't know how much pain the patient's in, ask your partner. Have them make it up. Have you taken your meds today? How's your diabetes today? I know there were like 2 patients that had diabetes or something like that. Figure something out. Ask appropriate questions. I want you to start developing those skills now rather than waiting until later. So let's do a case. Anybody can pick, I don't care who, pick a case in the book and let's go through it, and I'll demonstrate all of those. So that way you have an idea of what we're looking for.
Can we do the 113, case 45?
Sure, I don't have any of these cases memorized, so tell me the case.
I haven't read the case.
Just summarize it. Anybody want to summarize it?
What's the title?
Obstipation due to the bladder problem. It's like a bladder problem.
Obstipation?
Yeah.
Some metastasis?
You say obstipation, I hear constipation. And then you say bladder, so I'm like, what's going on?
That's a serious issue.
It really is.
Okay, so we have a 75-year-old Caucasian male, came to the emergency with SLB. He also has COPD.
Okay, just from that, we know that older gentlemen, that's already a yellow flag. The older you are, the more likely you're going to have more problems, because that's what happens. You're more likely to have problems when you're a baby, and you're more likely to have problems when you're older. In the middle, you're supposed to have, quote unquote, a healthy life, right? More likely to die when you're a baby, more likely to die when you're older. And then middle age, if you're a guy and doing stupid stuff. We'll talk about that in TBI, it's upcoming, right? This guy also has lung issues based on what you told me. So just from the first 2 sentences, lung issues, older male. Let's go.
And then while in the hospital, he has hypotension and was started on dopamine. Experts show that he has pulmonary edema.
Okay,
leading to,
so just from that,
HF.
you said hypotension?
Yes, hypotension.
Okay, so this is interesting already. Hypotension is high or low blood pressure?
Low.
Low blood pressure. And then he said that he was prescribed dopamine. So that is telling me that this guy likely has Parkinson's, right? But what is dopamine going to do? We haven't talked about this yet, but apparently it's in your case.
It affects the face.
It does.
Slowing down.
It's going to slow it down. The way to remember that, what does dope do? If anybody, if you ever do dope, what is that going to do? It's going to calm you down,
Feels good.
right? No, this is how we're going to remember these things, right? So dopamine is going to do very similar things. It's going to calm you down. Okay, it's going to bring This is why people with Parkinson's have a difficulty time sleeping. That dopamine is not active and their brain is always going. That's why they always have the shakes. They always have tremors, right? By having dopamine, it calms the tremors down, but then they over-exaggerate with other things. So in this case, we have an older male. He has breathing issues, low blood pressure, and he's on dopamine. That already is telling me there's problems going on because dopamine is going to calm everything down. It's going to reduce his rate of breathing, reduce his blood pressure even more. So from a therapy standpoint, this guy's a fall risk. He's likely going to fall, and he really will have difficulty moving and ambulating and all of those things. So let's keep going, see what else we find.
Okay, so following removal of the NG2, he complains of severe low back pain and was started on Vicodin. MRI shows that he has lumbar and sacral spine show multiple level of lumbar stenosis.
Okay, so just from there, so this guy, now we're adding a lot more pathologies here. So not only does he have breathing issues and Parkinson's, he also apparently had some other issues in the hospital, and now he has back problems. What's going on with this guy, right? Stenosis means what? Not hardening, narrowing is the key word. With narrowing of the spine, we haven't really covered this yet. This is going to be something we really get into next semester. Anybody know what kind of exercises we're going to do and not do for this patient?
Not do some spine exercise.
We are going to do spinal exercises, but are we going to do flexion or extension? We're going to avoid extension and do flexion, right? Because if that spinal area is narrowed, if I extend, pop, right? As soon as you extend, you're going to crack and cause a fracture in the spine. So we want to do more flexion, because that's going to keep opening those facets, and it's going to decrease the space anteriorly, but increase it posteriorly where likely the stenosis is. Does that make sense? So flexion exercises are going to be great. So maybe for this guy, when we get into some exercises, need a chest exercise. That's what I'm thinking already. Let's keep going.
Okay, current complaint, spine report increased SLB with minor exertions and severe lumbar sacral pain that has been constant over the last 3 days and appears to get worse. Pain is described as dull ache and is aggravated by movement.
Okay, just from there, so he literally has a pain in the low back and pain in the butt. That's what he has, right? And she said that the pain is described as a dull pain. Whenever you see the word dull or achy, we're thinking muscle. If you ever see sharp, stingy, burning, now we're thinking nerve, right? If you ever see the words throbbing, pulsating, comes and goes, now we're thinking it has something to do with blood flow, maybe arteries or veins. So based on what she just said, if it is dull and achy, we know it's a muscular issue and it's in the low back. Maybe if it's really in the butt region, maybe it's a piriformis issue. But since there's no numbness and tingling as of yet, I'm assuming it's higher up. So I'm thinking it's more across the low back, maybe a quadratus lumborum issue or a low back erector spinae issue. I don't know yet until I put my hands on this patient, but that's what I'm assuming based on the case scenario. Let's keep going.
Okay. Minor relief obtained through rest and use of medications. Patient also reported recent low abdominal discomfort when he attributed to something he ate for breakfast.
Okay, just stopping right there from, he's saying he's having abdominal pain. This guy's taking Vicodin for muscle spasms, right? Number one, that Vicodin is not going to help him as much because he's also taking dopamine. Dopamine is already trying to calm everything down. Now he's taking Vicodin to bring everything down. Everything's going to become super low tone. Side effects of Vicodin, you're going to have an increase in liver toxicity. So one thing that we would be careful of is intra-abdominal breathing. So I'd really like to look at the color of his stool. Make sure that he doesn't have what we call melena, which is blood in the stool, which would indicate intra-abdominal bleeding. I would also maybe like to know that pain, how close is it to the medication? Because it could cause GI disturbances, all the medications he's on, right? So what else do we have?
Long history, progressed back pain with trauma onset starting in his 40s. His immediate goal is relief of back pain. His normal back pain is rated as 4 to 6 on a 0 to 10 scale. His current level of intensity is described as 8 out of 10.
Okay.
On pain med.
Okay, is there anything else, main information, or is that pretty much the case?
No, and the rest of them
It's worse with
is
movement.
Okay, worse with movement. So overall, you got a guy with a lot of problems. He's got Parkinson's, he has COPD, or basically some sort of lung pathology that they haven't been able to figure out yet. Breathing difficulties, now he's starting to get abdominal cramping and pains for whatever reason, and he has a lot of back pain. What's going on with this guy? We really don't know. We just know he's in a lot of pain. So for the purpose of your exam, we're gonna say this guy is, all the other random stuff is cured. He has nothing else except a low back pain. So now you start your test, okay? From here, active and passive range. So to assess active or passive range, let's say we want to do it for his back. One thing I could do for active range of motion for his back extensors or flexors, I could say, Micah, can you stand for me? Can you try to touch your toes? Perfect. And back, yeah, I know. That was good. Okay, so that would be active range for hip flexion, right? Or low back flexion. Both are involved. I could also assess that with him in supine. So lay on your back. So actively, I could put a ball under his legs if he's not strong enough, or I can stabilize under his hip, under his knee, and bring it up and assess it that way and see what kind of end feel I have, right? I would say soft or firm end feel. He's for the most part firm. I'm trying to give you a compliment. Okay? Let's do. Okay, so soft or firm, whatever that may be. So that'd be the very first one. We positioned him. I did active range and I did passive range, and I told you the end feel. So that's done, that section. Second thing, resistive or strength training. You could make anything resistive or strength training. What do we want to do for this guy? Make something up.
Posterior pelvic tilts.
Okay, posterior pelvic tilt. But is that, how can I make that a resistive training?
Add a weight.
Your hand here.
Yeah, I could add my hand in the front and have him push against that or pull up against that, right? That's resistance. It's not bad. Or if I don't put anything on him and have him do that actively like 10, 20 times, that becomes more of an aerobic exercise. That's the next one. Dynadisc, that'd be really good if you want to use that for balance. That's a really good one. We also have the biofeedback device for the low back. You could put that under his back and pump that up and have him resist that. Why not? There's a lot that you can do.
And here it shows that his outcome diagnosis, he has bladder, but we can't remember the last time he has bowel movement. He has bladder, outlet obstruction, UTI, prostate cancer, and obstipation.
Yeah, he has a lot of stuff wrong with him. But when we get into geriatrics, we'll talk about that. One of the things, if somebody does complain of low back pain, one of the things that I always think about, and if they're confused, so confusion and low back pain, that's almost a red flag that this guy has a UTI. Almost always. The other thing that we'll learn about when we get into geriatrics is if somebody has a hip pain or any type of hip issue, I'm always going to ask them about bowel and bladder issues. Because bowel and bladder is going to refer pain to the hip. And that's why it's going to wrap around the hip and go to the back. That's why they might have difficulty with abduction. That's why they'll have like a waddling gait sometimes. And if they have a waddling gait, what is going to happen? Not only do they look like a penguin, they're going to increase risk of falls, especially in the bathroom. And when we get into spinal cord injuries, we'll talk about what happens with especially an anterior cord injury or a central cord issue when they fall like forwards like this, and this part of the spinal cord goes backwards, and now they lose the ability for motor control. But they have full sensation. It's really weird. And that's very common in older folks. Okay, so we did active passive range of motion. Stretching. So with stretching, it's hard to stretch the low back sometimes. So using the whole Janda approach, right? If the low back is tight, right? If the low back is tight, your quads are likely tight, right? So sometimes rather than stretching the low back, why don't we stretch the quads? So for that, I would say, Micah, can you lay on your stomach for me? So if he lays on the stomach, I know I would go on the other side because that was the leg I've been working on, but for right now, we'll just pretend it's this side. And all I would do is bend his knee, and he would start feeling a stretch slightly. If you want a deeper stretch, when we actually get into it more, you can stabilize. I actually like going like this and doing contract, relax. We'll do a little bit more of this next week with PNF. And I can say, Mike, can you push against me? Push, 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 and relax. And then I can go deeper. Right? So that's contract, relax, all for increasing range. But we'll do that next week with PNF.
Can you do the William flexion? Would that be a good one for low back?
What? As long as it makes sense, and that's something that you guys know how to do and you're comfortable with, go for it. I won't stop you. I'm not even grading you on this thing. As long as you can make sense of it, right? As long as you can make sense of why you're going to be wanting to do something, go for it.
Okay.
You're going to be the clinician. We're not always going to be there telling you what to do. So I want you to think about why you would do something or not do something. If it makes sense and you can explain it, more power to you, go for it. You guys know more exercises than I do. Mix and match, make something up, okay? So the next one, we can do aerobic or balance training. So this guy, we can do both. So it really doesn't matter. Let's say he's always in pain, so for aerobic exercise is really good for decreasing pain. Maybe having him sit and taking the little bicycle and having his feet in there and going through there. Not only is he increasing flexion, thereby hopefully decreasing the pain, maybe he's just getting some aerobic workout, especially because it's lung issues. Or just having him sit and do upper body. That's fine too, because now he's flexed this way. Perfectly acceptable. Or what about some breathing exercises? In through the nose and out through the mouth. Right? I'm trying to get more diaphragmatic, so as he inhales, his chest should expand. For balance, this guy you might want to do standing, but he seems like he's older and he has a lot of issues. We could do standing balance, eyes open, eyes closed, change the surface, hard and compliant surface. We could also just do balance training as he's in this position. Why not put a foam pad under his butt right now and have him push into it? That's hard, right? Or have him do some bridging exercises. Because we're pretending he does not have a UTI right now. We're pretending all he has is low back pain. Because if he had a UTI, you have to be very careful with that. In fact, try not to work too much on the lower extremity. After that, you're going to answer the questions. So what are the questions that I ask in the book?
List the red flag signs.
Okay, so it's almost always tell me the red flag. So what are the red flags? Age is a red flag for this guy, right? Because he's older. We don't know he has cancer. Okay, all of these medications that are increasing drowsiness. Vicodin especially can lead to GI disturbances. So that's definitely something that we can look at. What else? Was he confused? I'm assuming he was confused because if it says UTI, almost every single time they'll write he's confused. Let's say he's confused. I don't know, I haven't read the case. But if it isn't, you can say likely if he has a UTI, maybe he'll be confused. Because he didn't even remember the last time he went to the bathroom, so I'm saying he's confused. Okay? I think most people remember the last time they went to the bathroom. Are you confused? Okay, so age, medications, all of this confusion, those are red flags. Any other questions that are there?
No, just that one.
Just one. So you're lucky. I guess if you get this case, you only have to answer the red flags question. Some of the other cases have 2 or 3 questions. Like what are the functional limitations? What are the activity limitations? So depends on what case you get, you'll have to be able to answer that. And then you document. So does that make sense about everything that we are doing with it? You can make up whatever exercise you want. You have the full gym, right? There's only going to be 6 of you in this room at a time anyway, and that's 3 groups. So that means only 3 clinicians. There should be enough room and basically wiggle room to do whatever you want. Feel free, if this guy has low back pain, forget the age and say, if he was healthier, maybe you want to do an exercise on the inversion table. Maybe you want to do more standing exercises and do internal external rotation. or attach a band to him and just stand with a TheraBand behind him or in front of him, and he's leaning. On that device or that device. We haven't really played with the TRX, but feel free to use it on your test. Throw it over the door and say, hey, we're working on stability and balance that way. I don't know, make it up. You have, for balance, we have your AirX pad. You have your balance disc. You have your Bosu ball. You have the trampoline you could stand on or throw balls against, right? Having both legs or bilateral, single leg stand, eyes open, eyes closed, static, dynamic. Anything else that you guys have covered or have questions about? Is that making sense? Hopefully that we ran through the whole example. Yes, no? You guys are always so quiet, so I never know if things are making sense. That's why I always keep asking. Okay, okay, hopefully it is. Yeah, ma'am.
For the other cases, are you gonna give us what we need to know, what we need to perform with the impairment? Like, this one you told us is low back. So
Well, all of them have, it tells you what's wrong in the case. I didn't know it was low back, that's what,
Oh, so
Kate
you're
told me.
just it did say low
It said low
but
back in that case.
someplace-
In the other, I think there's two cases that are low back, I think low. Here and there for a nail issue, that's not a reason why you go to therapy. If you have white nails, you know.
So just basically disregard all the additional.
Yeah, so just focus on the orthopedic rationale of why they're in physical therapy, and then that's what we're treating. For example, the lady, I remember the very first case, you have a lady with a, we know that the fibula is fractured, right? What muscles are on the fibula? The fibularis muscles or the peroneal muscles. What do? Eversion. So what I can do with this lady is, I want you to take your toes and bring it out all the way to the door. Can you do that? Oh, let's try to keep that steady, right? Good. And I'm happy he did that because your patients will do that, not might, they will do that. So you have to be able to recognize and correct that, okay? So that's active range. In passive range, I can do the same thing. I can go down, I can even put his leg right on top of me, do active that way, and then move his foot. I can say, oh, that seems like a hard infield. That makes sense because of the bones. Or it's an empty infield because my patient started screaming, ow, 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 that hurts. That would also make sense because of the fracture, right? If it was DVT, it would hurt a lot back here, and that you're going to be feeling and sensing, right? So if that's the case, it says for the first one, active and passive range, stretching. If she has an everter issue, likely her supinators are tight, so we can stretch her into that eversion, bring her out until she basically screams, but not so she screams, right? Just stretch it a little bit. Or if you're thinking that it is a gastroc issue because she has a DVT, well, we don't really want to stretch that, right? Because if we stretch that, this becomes too tight, and then we let it go. It goes all the way up into the lungs or the brain, and she has a PE, pulmonary embolism, or a stroke. Or it goes to the heart and you have a heart attack.
Just kill me, Judge.
Yeah. But what we can do is, if there's a problem with the everters, using the whole weird Jonda approach, because this is a lateral muscle, we can follow it up laterally. So if this muscle is weak, that means your adductors are weak, likely her abductors are tight. So we can stretch the abductors, right? So that's how you can always think about the human body. Always go in the cross pattern. Your lives will be much, much easier. Okay? So if that's the case, as long as you can tell me, I would not work on the muscles right here because of the fracture. If I overstretch it, I could cause pain. So I'm going to work on the hip. I'm going to stretch her abductors or adductors, whatever, as long as you can rationalize it. Just say, I would palpate, see what's tight, and then we'd go from there. The other thing you should remember about stretching, she's an older lady, so for people that are older, you're going to have more static stretching. So we're usually 30 seconds to 60 seconds. If they're younger, 10 to 20 seconds is more than enough. And by younger, I mean probably 45, 50 or less is considered young. Anybody over 50 is considered old, I guess. I don't know. For that one, resistive training or strength training, I could do manual resistance, just put my hand here and have him push out against it. I could do plantar flexion, dorsiflexion. Can you push against my hand? Push, 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 push. I know it looks a lot like manual muscle resistance or MMTs, but it's actually exercise. As you're doing that, if I was on that side, I would have one hand behind his back for stability. Don't just have both hands here. Because as he's pushing out, what's he gonna do? He's gonna go back to compensate. So I have to make sure he doesn't do that. And the whole entire time, make sure his abdominals are engaged. Next one, aerobic or balance. This lady has a fracture, so balance training is really, really good. So I could have her just standing is really good. Eyes open, eyes closed, to get that proprioception back. How would I progress it? Put her on her X pad, or eyes open, eyes closed. Maybe just perturbation, me pushing her, right? Not shoving, but pushing lightly. How would you explain that? Perturbations to assess ankle strategy, right? Or moderate perturbations to assess hip strategy. Maximal perturbations to engage stepping strategy. That's how we are going to be documenting this. The next one, well, that's it. Then clinical relevance, answer whatever question. What are the red flags? If I remember correctly, that lady had a bunch of upper motor neuron symptoms, and then you document. Does that make sense? Putting things into perspective? I think everybody's just overthinking it. Make things as stupid simple as possible, right? Because that's what it should be. The more fancy you make things, the more you increase the risk of mistakes. The simpler it is, if you make a mistake, you know what that mistake is. You can fix it. Okay. Any other questions, comments, concerns? Vanessa, is that a question or just? Any other questions? No questions.